Bonjour tout le monde, je vous remercie beaucoup de vous être connectés pour cette seconde conférence de ce cycle qu'on a appelé cette année les cours de la Fondation FondaMental et qui est consacré aux thérapies psychosociales. On est aujourd'hui très heureux d'accueillir Anabel Martínez-Arán qui est déjà venue plusieurs fois faire des conférences dans la Fondation FondaMental, qui est une grande spécialiste des thérapies psychosociales dans les troubles bipolaires. Comme vous le savez, elle travaille au centre, à l'unité des prises en charge des troubles bipolaires et de la dépression de l'hôpital de Barcelone, qui est une unité extrêmement connue, dirigée par le professeur Eduard Vieta, et elle est professeure associée à l'université de Barcelone. Alors, elle va nous parler en anglais. Vous pourrez bien sûr poser vos questions sur le chat en français si vous le souhaitez, et je les traduirai. Il n'y a pas de problème. Et on a aussi la très grande chance que le professeur Bruno Etain de l'hôpital Lariboisière, qui est le coordonnateur avec le professeur Émilie Ollier du réseau des centres experts bipolaires, ait accepté de modérer cette conférence et d'interagir avec Anabel. Anabel, the floor is yours.
Okay, bonjour, merci Marion et Bruno pour l'invitation à participer à cette série of conference. I'm going to speak in English, which is not much better than my French, so sorry. The contents of this psychological integrative approach have been selected on the basis of our experience of around 20 years conducting psychoeducation groups and more than 10 years with functional remediation groups. Other components are related to mindfulness and healthy lifestyle promotion, and have been also included as part of this integrative approach, as we will see later. This is my disclosure with potential conflicts of interest. And why is it important to complement pharmacological treatment with psychological therapy? Adjunctive psychological interventions would ensure the effect of medication through promoting good adherence and would address other aspects that medication alone cannot reach. Different psychological treatments have been developed and tested in bipolar disorders, but despite the recommendation of clinical guidelines, some studies report that only a minority of individuals with bipolar disorder received psychotherapy. This is a list of targets considered by psychological treatments in bipolar disorder. First of all, educating about illness and its treatment, correcting myths, false beliefs, and misattributions, working with acceptance and awareness, enhancing medication adherence, promoting healthy and regular habits, avoiding substance abuse or dependence, improving early detection and early intervention, training in stress management, teaching emotional self-regulation skills, improving cognitive and psychosocial functioning, as well as well-being and quality of life, training in social skills to improve interpersonal relationships, and improving family environment, providing support, promoting self-care, education and skills training for relatives to cope with the illness and to deal with the stress. We're going to talk today about the therapeutic components of broader psychological approaches that the Barcelona Bipolar Disorders Unit developed and whose efficacy has been evaluated separately, such as psychoeducation for patients and relatives and functional remediation. In addition, a module on mindfulness-based cognitive therapy is included, and these are basically the foundation of this integrative approach. This approach was born from our program, Clinical Practice, Teaching and Research on Bipolar Disorder, undertaken over the course of more than 2 decades, and involving patients and relatives as active participants in the therapeutic process. This integrative approach offers the opportunity to integrate, to recognize intervention, psychoeducation, and functional remediation in order to improve functioning of our patients, and include some elements from mindfulness to enhance attention, mood regulation, sleep, and anxiety that are affected in a significant percentage of bipolar patients. As you know, psychoeducation is a therapeutic approach that attempts to provide a theoretical and practical framework in which those who suffer from the illness and they can better understand and face the disorder and its possible consequences, actively participating in the treatment. Several psychoeducational manuals have been developed for clinicians working with patients with bipolar disorder. In this presentation, the Barcelona psychoeducation programs for patients and relatives will be taken as reference, and both have inspired the psychoeducation module of integrative approach, as we will see in the last part of the presentation. The Barcelona psychoeducation program for patients consists of 21 group sessions of 90 minutes each. Once a week, psychoeducation can be carried out in an individual or group format. Working with groups is not only a less expensive option, but also offers an appropriate framework for working on disease awareness and fighting stigma. Groups facilitate the modeling and increase support and social network for participants. The program is manualized. It's advisable to work with therapists and to include more or less 10 patients per group. And it's very important to promote interaction and communication. Psychoeducation goes beyond the mere transmission of information. Psychoeducation leads to cognitive and behavioral changes for which it must involve training in practical skills that improve subjects' competence in coping with the disease. So psychoeducation implies working with awareness and acceptance of the illness, with responsibility, with a proactive attitude, and promoting therapeutic relationships relying on information, collaboration in decision-making, and trust. Psychoeducation involves replacing inflexible appointment system by easy accessibility to clinicians and on-call availability, and also implicates replacing one clinician by a multidisciplinary team. In the original program, 21 sessions are grouped into 5 blocks or modules. First one, awareness of the disorder. The biological, chronic, and recurrent nature of bipolar disorder is highlighted. Working on these aspects is crucial for understanding and accepting the need for long treatment. In this context, establishing the distinction between causes and triggers is clarifying as well. It also places the person in an active and responsible position by realizing that, although the risk of relapse is always present, some behaviors can reduce such risk and contribute to keeping the disease under control. Symptoms specific to each episode are reviewed in this module, as well as the aspects related to the course of the illness. Another module focuses on enhancing drug adherence, providing information about different pharmacological treatments and their therapeutic and adverse effects. Doubts and fears are addressed. Next module addresses avoiding substance abuse. Even if patients of the group don't have serious problems of drug use, it's important that any program with bipolar patients highlights need to avoid certain types of substances. Next module, early detection of relapses, is important. It implies early detection of first warning signs of prodromes of new episodes, including the development of a personalized prodrome list, exposing qualitative and quantitative changes as objectively as possible. Finally, last module focuses on regular habits and stress management, since they play an important role in reducing the risk of relapses. This module emphasizes the need to keep a healthy lifestyle that incorporates physical exercise, an adequate eating pattern, as well as an average of 8 hours of sleep as protective factors and strategies for stress management, such as relaxation and problem-solving training. 120 bipolar patients, euphemic patients who were receiving a standard pharmacological treatment were included in a controlled trial. Subjects were randomized to receive, in addition to standard psychiatric care, 21 sessions of group psychoeducation or 21 sessions of non-structured group meetings. Subjects were assessed during 21-week treatment period and throughout a 2-year follow-up. And group psychoeducation significantly reduced number of relapsed patients and number of recurrences per patient, and increased time to depressive, manic, hypomanic, and mixed recurrences compared with the control group. At 5-year follow-up, time to any recurrence was longer for the psychoeducation group compared to the control group. The psychoeducation group had fewer recurrences of any type, and they spent less time acutely ill, as you can see here. So 6-month group psychoeducation has long-lasting prophylactic effects in individuals with bipolar disorder, so that this findings suggest that its intervention is helpful to prevent relapses. Why is it important to involve family members? Bipolar disorder affects not only the patient, but also the people with whom he or she lives. Studies on expressed emotion have shown that the presence of relatives' critical comments, for example, she doesn't collaborate in housework, or hostility, he's lazy, has negative influence on the course of the illness. So a continuum could be established whose strengths are at one end denial and at the other hypervigilance. One of the aims of family psychoeducation is to use emotions constructively and encourage changes to positions that are more beneficial for the patient and the family members themselves, facilitating acceptance and proactive attitude through the use of adaptive coping strategies that also increase sense of control and self-efficacy. As mentioned before, there are different formats and types of family interventions. Here we describe the contents of the program delivered to family caregivers of patients with bipolar disorder. This was carried out at Hospital Clinic in Barcelona, and the intervention consisted of 12 group sessions of 90 minutes each, held once a week. The program is very similar to the one presented on psychoeducation for patients, but shorter and with more emphasis on the role of family members, promoting attitudes and behaviors favorable to themselves for the illness, and also for stress management and communication skills training. As we will see later, the integrative approach includes a session delivered to relatives. Psychoeducation group intervention focused on caregivers carried a reduction of the percentage of patients with any mood recurrence. When different types of episodes were analyzed separately, the effect was significant for both a number of patients who experienced hypomanic or manic recurrences, but the differences in prevented depressive and mixed episodes were not significant. Psychoeducation group intervention for caregivers is useful adjunct to usual treatment for patients in reducing the risk of recurrences, particularly mania and hypomania. I don't know if you have any question after this session.
So thank you, Anabel. We will make a first stop here for a few questions about psychoeducation program. I have one first question to you. The first one is that it seems that you have groups for patients and you have groups for family members. is there any opportunity to have groups with mixed people, so meaning patient plus the family, or do you always use separate group, one for the patient and one for the family?
Okay, in general, in a hospital clinic of Barcelona, patients and relatives participate in separate groups. We prefer to give both patients and relatives their own space to feel free to communicate their fears and doubts. Main reasons for this format is that it allows the identification and exchange of experiences among equals, facilitates expression and normalization and handling of emotions, and increases support, social networks, and the importance of self-care. However, sometimes perhaps it's necessary to work with single family units, especially in case of relatives of recently diagnosed patients, since they may be alarmed by more severe cases, or it may be useful to have this patient and family members together when it's a case of a more personalized approach and objectives. In the integrative approach, relatives are also invited to one of the sessions, as we will see later, and it's also addressed specifically to family members.
Okay. And I've got one other question, because we are now seeing the development of online psychoeducational tools and also apps on smartphone that can measure some symptoms and deliver also some psychoeducational information. What is your feeling about this new way to deliver such psychosocial intervention? And is this something that by definition does not replace groups, or can this be a surrogate, for example, for patients who cannot attend some psychoeducation session because they are living too far or they are working, being not available?
Okay, this is a very good question. This was one of the ideas of the integrative approach. We try to shorten contents of psychoeducation and functional programs. The aim was to prevent relapses and improve functioning. We haven't developed booster sessions, and with regard to the use of applications, we developed an application called Simple to reach bigger audience and acceptability, and the experience was very positive, demonstrated to be useful and satisfactory for patients. And we're trying to include applications and to use other approaches for people who can attend the sessions. Actually, we use apps to complement the contents of the integrative approach, as we will see later, for mindfulness, training for physical exercise or nutrition, regularity of habits. We are trying to offer the patients applications for all these issues.
Okay, thank you, Anabel. Maybe we can move forwards.
Okay. Okay. Another program developed in our unit more than 10 years ago was functional remediation. It represents a scientific effort to build psychological intervention aimed at solving the functional problems of bipolar patients facing cognitive deficits associated with the illness, adapted to the characteristics and the specific needs of this population. And several years ago, our team published a study comparing patients with bipolar disorder across different clinical states, and we found that cognitive impairment persisted beyond the acute episodes of the illness, and most affected areas were attention, memory, and executive function. Not only bipolar 1, but also bipolar 2 patients show significant impairments, with bipolar 2 showing an intermediate level of performance compared to bipolar 1 and healthy controls. Cognitive deficits were associated with longer duration of illness, with higher number of manic episodes, and deficits were higher in patients with previous history of psychotic symptoms compared to those without. Probably the most important finding was the relation between neurocognitive performance and psychosocial functioning in these patients, so that cognitive impairment should be considered a critical clinical and therapeutic target and challenge. High variability in functioning may derive from a wide range of factors such as sociodemographic, clinical, pharmacological, and neurocognitive variables. This consensus that cognitive deficits have an adverse impact on functional outcome in affective disorders. Therefore, cognitive abilities, including memory, planning, problem-solving skills, for instance, are probably needed to cope with the different psychosocial situations. In this regard, our team developed a functional remediation program at Hospital Clinic of Barcelona, with main objective of treating not only cognition, but also functional impairment in bipolar disorder. And this protocol emphasized the education about cognitive deficits and their impact in daily life, as well as training of functional skills using real-life exercises. The program is based on a neurocognitive behavioral approach, including modeling techniques, role-playing, self-instructions, positive reinforcement, and metacognition. Then I'm going to explain very briefly the program and some results on its efficacy. Basically, the functional remediation program provides in 21 weekly sessions grouped into 5 blocks, strategies to manage the main cognitive deficits associated with bipolar disorder, that is attention, memory, and executive functions. First block provides information about the most common deficits in bipolar disorder, how cognitive problems influence daily function, read a book, follow longer conversations, for instance, and what are the risk factors for cognitive impairments, for example, physical inactivity, poor diet, stress, relapses, use of alcohol and other drugs. Relatives are involved in one of the sessions to provide information about the issues and these issues and how to help during the treatment, giving them practical advice since they have an important role on enhancing practice through reinforcement. The second block provides strategies to improve attention using adaptive strategies, limiting distracting stimuli when they were establishing regular routines, breaks every hour. And in the module of memory, compensatory strategies such as use of calendar, diary, mobile phone organizer, and other internal strategies such as categorization or association are provided. Executive functions module focuses on the use of self-instructions, time management, and problem-solving techniques. And finally, last block addresses some communication skills and strategies for stress management in order to promote patients' autonomy. The efficacy of functional remediation was proven in a randomized controlled trial with the participation of 10 sites, Spanish sites involved in the fever SAM, in the fever of mental health. To be enrolled in the study, patients had to be euthenic and 2% moderate to severe functional impairment assessed through the FAST. Patients were randomized to receive only one of the 3 arms, functional remediation program, psychoeducation program, or pharmacological treatment as usual. And the primary outcome variable in the study was a functional improvement measured as the mean change in the FAST scale from baseline to endpoint after each intervention. Regarding treatment effect, data revealed a significant functional improvement from baseline to endpoint in the functional remediation group compared to treatment as usual. We also analyzed possible changes in each domain of the FAST, and functional remediation showed superiority when compared with treatment as usual in the interpersonal domain and the occupational domain as well. And despite the significant improvements in psychosocial functioning, no significant effect of treatment group was found on neurocognitive variables. At 1-year follow-up, we detected positive effect of functional remediation over time. When compared with the other 2 groups, there was a reduction of more than 6 points in FAST in the functional remediation group from baseline to endpoint, indicating a significant functional improvement. Therefore, the effect of functional remediation remains over 6 months of no further therapy. When it was time to analyze its FAST domain, we found that only autonomy significantly differed between groups in favor of the functional remediation group. And this domain refers to the capacity of doing things alone, taking our own decisions and with more self-responsibility. We found significant improvement in verbal memory for patients receiving functional remediation compared with the other 2 treatment groups. And we found significant correlation between improvement in verbal memory and functional changes over time. Okay, I don't know if you have any questions.
Yeah, we will have a second stop. Thank you for that. I've got one question, which is a very practical one. So when you receive in your center an individual who can benefit both from cognitive remediation and psychoeducation, what is the order you provide intervention? Do they go first for cognitive remediation or first with psychoeducation? Is there a specific order we have to propose this kind of interventions?
This is a difficult question. But it's very interesting to think about it, because in our experience, we think that it's better to start with psychoeducation. Patients need to have some knowledge about the illness before. They need strategies to manage symptoms, to regulate habits, to prevent relapses. And this is the first step to prevent and reduce cognitive dysfunctions and to have, in the long term, better functional prognosis. Psychoeducation is important in the early stages of the illness, and functional remediation was created to improve cognition and functioning, but in patients with more chronic course of the illness with multiple episodes. However, if cognitive and functional difficulties are detected after first episode of the illness, we can offer functional remediation as well. But I think that the benefit is greater and adherence is better if the patient is psychoeducated before. Perhaps the only exception may be in patients with first psychotic episode. Sometimes they show cognitive problems very early, and they accept better cognitive enhancement rather than psychoeducation.
Yeah.
So in the integrative approaches, we will see later, we start with psychoeducation. At the end of the intervention, we offer strategies from functional remediation. And this is the order in this program.
Okay. And I've got a second question about the outcome of your trial comparing cognitive remediation and psychoeducation. So in the study, the outcome is functioning. And did you also look at relapses in order if cognitive remediation is also a tool to prevent relapse or not?
We didn't get significant differences between groups with regard to reduction of relapses. So perhaps we need longer follow-up to have these positive results in these variables. There was a secondary outcome variable, but in general, psychoeducation is better in the prevention of relapses and functional remediation in improving functioning. So we couldn't observe these changes in the case of functional remediation for relapses.
Okay. Thank you, Anabel. We can move forward.
Okay. Okay, so let's move to mindfulness module. Mindfulness perhaps is an approach that has gradually gained strength as treatment or complement to many interventions aimed at reducing stress and the anxious and depressive symptomatology that often accompanies it. Mindfulness means paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. This allows the person to observe and be more aware of thoughts, feelings, and physical sensations, so which in turn puts the person in a position of responding more skillfully. And we didn't have any previous experience with the use of these strategies in our group interventions for bipolar disorder, but we have used them in individual psychotherapy with positive results and good acceptance. This is a summary of exercises that can be done in formal and informal practice. Formal practice, as you know, is that which is done in a regulated way, adopting specific posture and reserving specific time of the day to do it, using help of an audio guide, for instance. An informal practice can be carried out at any time, applying it to activities of daily life, such as brushing your teeth, cooking, eating, walking, listening to someone. Bringing back the wandering mind requires effort, as in any kind of training. But in a similar way, the more we do, the more we practice, the easier it becomes. For the reason, we must reinforce practice and encourage persistence. Why incorporate mindfulness into an integrative approach to bipolar disorder? Because it may be helpful to have better awareness of changes in mood, changes in a state of mind, changes in these physical sensations, be more aware of first warning signs of relapses, activating appropriate strategies, and may be helpful in training attention, for improved focus and concentration, for better management of anxiety and management of depressive subsyndromic symptoms. May be useful to reduce rumination that is frequent in patients with depressive symptomatology, with improvement of emotional self-regulation, may also reduce automatic responses, for example, impulsivity and hyperreactivity, and it allows be more connected with present moment and increase the sensation of well-being. Okay, this is the last part of the presentation. The integrative approach was designed based on combination of different psychological treatments previously described. Some contents of psychoeducation for patients have been combined with session for family members and complemented with aspects related to health promotion, mindfulness training, strategies for cognitive and functional enhancement, always as adjunctive to pharmacological treatment. And this manual was published last year in English by Cambridge University Press, and it will be available in Spanish in 2021. All the materials for patients are included in the manual. Why is an integrative approach necessary? Because treatment of the disease should be comprehensive, taking into consideration different areas influenced by the illness. The sessions cover clinical aspects and issues related to physical health, cognitive and psychosocial functioning, and enhancement of well-being and quality of life. In order to address all these areas, the integrative approach was designed based on a combination of different psychological treatments. It's necessary to generalize intervention programs developed in specialized centers to usual clinical practice. In this case, components have been combined shorter form, facilitating this implementation. And this required the design and evaluation of potentially effective treatments that must be brief and feasible enough to be implemented more widely. In the same way, making the inclusion criteria more flexible would make it possible to cover a greater number of patients and would be more representative of the population with bipolar disorder. So we include in our groups euthymic patients, but also patients with subsyndromic symptoms, and people with other comorbid psychiatric illnesses are not excluded, with the exception of active drug abuse or dependence. The intervention can be carried out in either individual or group format. The program has a total of 12 weekly group sessions, each one lasting 90 minutes over a period of 3 months, conducted by 2 psychologists with clinical experience in the management of bipolar disorder, group dynamics, and with the different components of the treatment. The sessions are structured, dedicating the first few minutes to holding an informal conversation, including doubts or questions since the last session. Practical exercises are reviewed, or mindfulness practice introduced. After that, the topic of the day will be addressed, covering main objectives of each session with flexibility while encouraging participation and discussion. After each session, a summary of the topic worked on is delivered. Each block is complemented with additional information in the form of mobile applications, links, readings, and other resources that members can go deeper into the practice of exercises. To illustrate the contents of the sessions, a black or white board will be necessary, as well as a projector or screen as audiovisual support for presentation of slides in the functional remediation module. It's important that therapists and co-therapists have updated knowledge of bipolar disorder. as well as clinical experience in the management of the disease, and training in the techniques used and specific components of the integrative approach, such as mindfulness. Therapy should be familiar and comfortable with the group format. The use of humor on certain occasions can be used to deter a potentially tense situation, even when serious issues are addressed. And therapists should encourage participation of all the members. This table summarizes the program. The integrative approach consists of a psychoeducation for patients, including session just for family members. In addition, the promotion of regular and healthy habits, training in mindfulness, and resources and strategies for cognitive and functional enhancement are worked on, focusing on attention, memory, and executive functions. Some strategies such as problem-solving techniques and training in communication skills that are also used in other programs mentioned are incorporated in this module. So we have the first 5 sessions are more related to psychoeducation. Session from 6 to 8 focused on mindfulness, and last 4 sessions are part of this cognitive and functional enhancement module. You can see that there are practical exercises. We're going to look at some of them. For example, a useful exercise for psychoeducation block of sessions consists of drawing a graph with the evolution of the illness on a horizontal line reflecting the state of euthanasia over time. Different types of episodes experienced are represented. At the same time, it's convenient to write down dates corresponding to relapses, possible triggers, consequences of the episodes, and the treatment received. This exercise allows the subject to detect specific patterns. For example, if there is a seasonal pattern of, or if the relapses have occurred after potential triggers such as drug use, as well as to be more aware of the chronic and recurrent nature of a bipolar disorder, and not to underestimate the risks associated with relapses. For example, hospitalizations, breakups, overspending. Another helpful exercise consists of drawing up a list with about 10 prodromes for mania, hypomania, and the same for depression, if possible with help of a family member. To make the list as operative as possible, a valid prodrome should be based on observable behavior, since emotions are more subjective and difficult to evaluate. Subtle signs, since otherwise it would be a symptom. The presence on a regular basis before previous episodes, being available on a daily basis, and involving a certain distinction from the person's temperament and habits. For example, initiating conversations with strangers will not have the same meaning in an extroverted person as in a shy person. A signal in isolation is not in itself a cause for alarm, but if more than 2 of these signals are presented repeatedly over the course of 2 or 3 days, it would be advisable to contact the clinician. Okay, in a unique session, we attend more specifically regularity of habits and promotion of a healthy lifestyle. Regularity of sleep patterns can be used as preventative tool and not only as an aspect to be treated in case of relapse. We recommend to follow a balanced diet, to plan meals, limit sugar intake, sit at table to eat, and other tips for healthy habits and healthy eating. Discuss with the doctor about fears of weight gain or possible side effects resulting from pharmacological treatment in order to agree the most appropriate treatment, or to establish some guidelines to compensate for side effects. Moderate physical exercise represents a great benefit not only for physical health but also for psychological well-being. Performing physical exercise could decrease risk of the depressive relapse, improve well-being, promoting changes in the brain, including decrease of inflammation, neural growth, and release of endorphins. It's also a way to reduce stress and improve memory and sleep regulation. So some tricks may be focused on activities like use the exercise as social activity, think about the reward, walk whenever you can, avoid elevators, increase your tasks at home. Deception to reduce drastically exercises in the case of an episode of mania or hypomania. When talking about psychological and physical health, it's essential to avoid drug abuse, since drugs are one of the most important risk factors in bipolar disorder because they can worsen course and prognosis of the disease. And finally, an essential feature of a healthy lifestyle is managing stress. Some practical exercises such as control, breathing training, explanation of the Jacobson's relaxation are done during the session, and different apps provided related to physical exercise, nutrition, mood monitoring, and regularity of habits. In this session addressed to family members, we'll provide some recommendations. Accept the illness, learn to detect warning signs, encourage good adherence to medication, promote healthy and regular habits, avoid blaming the patients, avoid criticism and overprotection, be tolerant, adjust expectations, learn to be assertive, self-observation, seek help when necessary, learn to relax and avoid isolation. And there are some, these are some of the practical exercises during sessions of mindfulness training, as well as between sessions. The content of these sessions have been adapted from the civil program. And you can see a guided practice of attention to breathing, body, sounds and thoughts, emotions, the present, and some as part of informal practice, mindful eating, walking, taking a shower, 3 minutes of breathing at least one a day, and resources, as mentioned before, are offered to further deepen the practice. In summary, mindfulness training can, among other things, make us more aware of our changes of state and also of first warning signs as of a possible relapse, to allow us to recognize stress more quickly and to look for strategies to better manage it, to facilitate greater emotional regulation and strategies for reduction of anxiety, to train our capacity of attention and concentration, and to be more compassionate with ourselves, to improve our responses so that they are less automatic, to enjoy present moment more. And practice is kept at the beginning of the following sessions and as exercises to practice at home. The cumulative experience over the past 10 years of implementing functional remediation program has served as guide to select the content considered essential to be included in the module of our cognitive and functional enhancement of the integrative approach. It includes many strategies, or the main strategies and techniques used to improve attentional capacity, memory, and executive functions. These are some examples, but we focus specifically more in the use of alarms, of lists and computers and mobile devices, and also in the use of internal strategies such as association, visual imagery, and categorization. And when focusing on executive functions, planning and organizing activities and time management are essential. So we work mainly on priorities. As you know, urgency does not make an issue more important. It's essential to know how to differentiate between these two dimensions, important, non-important, and urgent, not urgent. And the Eisenhower matrix includes these two dimensions of planning and time management. It may be a useful tool to use to increase our productivity or make us more effective in our daily life, especially at work. Finally, with regard to communication skills, we recommend to pay attention to both verbal and non-verbal communication. It's better to postpone important decisions if symptoms are present. Try to be specific and don't generalize, focusing on the behavior and not on the person. Transmit clear messages to avoid misinterpretations. Active listening, about substitute mind reading for direct questions, and be flexible, focus on the present, speak in first person, deal with one problem at a time, avoid distractions, and select the appropriate time and place to have an important conversation. If there is an issue that is difficult to address, you can turn to a trusted person or a specialist. What are the preliminary results from a randomized controlled trial with the main objective of testing the efficacy of this integrative approach in patients with bipolar disorder versus treatment as usual? Participants were recruited at Hospital Clinic of Barcelona, randomized to one of these two conditions, and they were assessed at baseline and 3-month follow-up after finishing the intervention. The main outcome variable included changes in psychosocial functioning assessed through the functioning and the FAST, and repeated measure analysis reveals significant group per time interaction in favor of patients who received the integrative approach compared to the treatment as usual group, improving functional outcome, the FAST total score, and significant effects were also found in 2 of 6 domains of the FAST, including cognitive domain and leisure time. Regarding secondary outcomes, significant reduction of depressive subsyndromic symptoms was detected in the group receiving the integrative approach. So this preliminary study suggests that the integrative approach represents promising cost-effective therapy to improve psychosocial functioning and the severe depressive symptoms in patients suffering from bipolar disorder. During the course of bipolar disorder, psychosocial functioning begins to decrease in the prodromal phase and first episodes in a subgroup of patients at least. And in this regard, psychological intervention should consider staging. Drug therapy and psychoeducation help to prevent relapses. Cognitive reserve enhancement may be helpful, particularly in the early stages, to prevent cognitive and functional decline. And functional remediation may be useful in more chronic patients with multiple episodes. The integrative approach was developed to treat those patients with persistent subsyndromal symptoms with comorbid conditions from the first episodes of the illness to more chronic forms, taking into account limitations of time and specialists to provide longer interventions. So, as conclusions, the reality of bipolar disorder is too complex to fragment, to split it. Hence the importance of an integrative approach that connects different aspects from a biopsychosocial perspective. Psychoeducation focuses on relapse prevention and functional remediation, on cognitive and functional improvement. The integrative approach is based on the need to cover different areas that may be affected by bipolar disorder by means of a brief intervention that can therefore be generalized to clinical practice. Preliminary results suggest that the integrative approach seems to improve functioning and reduce subsyndromal symptoms, and the advantages of combining pharmacological and psychological approaches would contribute to decreasing the burden of bipolar disorder by ensuring syndromal recovery through relapse prevention and functional recovery, which is crucial for the quality of life and well-being of patients and people close to them. Thank you very much for your attention, and thank you to my team in Barcelona.
Thank you, Anabel, and thank you for showing us this integrative approach and the preliminary data about the efficacy of this integrative approach. I've got one question, and maybe after Mario has checked the chat in order to see if there is some question also. So in Barcelona now, your approach is to provide only the integrative approach, or do you still have some patients who are going in psychoeducation, in cognitive remediation?
We had several problems to recruit patients for so long interventions, and it was difficult to carry out at the same time more than 2 or 3 groups of 6 months of duration. So, and for this reason, we thought about the possibility of shorten these interventions and to develop this integrative approach. So we're working with the integrative approach in the last 2 years, more or less, and there was a group of functional remediation which was stopped because of the pandemic, but we had the compromise of a project with functional remediation, and when this group has finished, only patients will be entered in the integrative approach groups.
Yeah, and in the context of the pandemic, do you have developed some distancial or by Zoom session to replace, for example, the psychoed group or something like that? Because we have here in the network quite a lot of difficulties to maintain this kind of activity for patients. So we have discussed but not been very successful to have this Zoom or by Skype session. So how is your position about that?
We maintain only individual therapy, and it was presential sessions or by telephone, but we were obliged to stop groups, and the alternative was to prepare all the material for online sessions. So we are in this process because the situation continues, and we are forced to give an answer, to give a response to these patients that are waiting for intervention. So we are forced to do it because we needed to avoid longer waiting lists, but we prefer face-to-face sessions to online interventions. Anyway, so I think that the face-to-face interventions facilitates group cohesion, interaction, communication, practical exercises, facilitates modeling, increases support, social network, and this is more difficult with online sessions.
Marion, do you have any question?
Yes, of course. Well, first I want to thank Anabel, because really it's very impressive over the years how your group and Edward Vieta has built such an enormous amount of data and tools to improve health of our patients. It's been both productive and really very, very impressive, and always scientifically very sound and productive. So congratulations, and thank you very much for having been so clear to demonstrate all these important tools. So I have a question, but before that, there are some questions from the audience, and in particular, Pauline Favre, who is a psychologist and works on mindfulness in particular. She asks you a question, which is the following: do you see any specific differential effect of the different interventions on emotion processing and regulation?
We haven't analyzed this data for our groups. We think that our experience is that the patients are more able to regulate emotions, and they reduce their levels of anxiety, and they are more able to detect warning signs and to have an early intervention in front of these early warning signs. And I think this is important, but we haven't analyzed the effect of or the impact of mindfulness in this integrative approach yet.
So, and she has a question which backs up to what I wanted to ask you. So I do understand the idea of integrating all these treatment strategies, but in parallel, do you see any specific profile of patients that would better benefit from one intervention or another? I remember at the very beginning of psychoeducation, your group was saying, which I do understand, that patients being at the very beginning of their disorder would more benefit from psychoeducation. And I think with the staging data, we need to think a little bit more on what is more beneficial for patients at different stages. Has this started in your group?
Yeah, I think that psychoeducation is very important, but 21 sessions is too long for, especially for patients with first episodes of the illness, and the idea was to shorten these interventions, and perhaps we're focusing more in cognitive reserve enhancement in this first episode patients, and to complement with psychoeducation as well, but it's difficult to use these long interventions in the early phases of the illness.
Okay, excellent. I don't think there are any questions. So as time is flying, unfortunately, we just have to thank you very, very much for all this hard work and all this amazing data. Hope to see you soon, face to face and not with a screen. Come soon, I hope. And I just want to say goodbye to all our colleagues that were behind their screen and remind them, maybe I will turn to French, notre prochaine session de ce parcours de thérapie psychosociale aura lieu donc le mercredi 10 mars et on aura une superbe conférence sur les thérapies en réalité virtuelle des troubles anxieux par Eric Malbos avec Antoine Pellissolo comme discutant. Donc, je vous donne rendez-vous à très, très bientôt.
Merci beaucoup.
Merci. Merci Bruno.